So what is the process of tuning AFOs? I have heard a lot about it but never experienced it with my daughter. What do I ask orthoticians or our physios to do? Okay, let's understand this. It's very simple. Let's go step by step. So what first we need to do is your orthotician needs to check your child's dorsiflexion range of motion. How much of dorsiflexion the child has with knee extension in prone position. Prone position would be better because the tone is inhibited in the prone. So that is advisable. Now in prone position, when they take the dorsiflexion range of motion, one thing which every therapist or an orthotician needs to be careful about is that they should keep the foot in subtalar neutral. When I say subtalar neutral, it should not be pronated like this, or it should not be supinated like this. It should not be supinated or it should not be pronated. Okay, it should be subtalar neutral. When you have subtalar neutral position, then all the joints of the foot are locked and foot is in a congruent position, in a stable position. So this is the position essentially which needs to be kept when you are taking the cast. Now, where do I take the cast? So for example, in subtalar neutral position, with knee extension in prone position, my dorsiflexion range of motion is, let's say I did the cast and I got it till -2 or neutral. So whatever you get, so after first catch, if you slowly and comfortably stretch, we call it, after R1, which is first catch, we call it R1A. So with comfortable stretch, whatever range you get, right, without building up tension in the calf muscle or the tendon, is where you ask your orthotician to measure the angle with the goniometer, and then wherever you want to take the cast. Prone should be preferable, but if prone or sitting, you take the cast exactly at that range, right? Once you take that range, you make AFOs at that range. Then, because we have kept because we didn't get the full range, maybe we were -2 degree, we were in 2 degree of plantar flexion, right? But we don't want tibia or the leg part to be at 90 degree, because otherwise it will pull the body back. We want it little forward, like you can see in this plane. This part, the leg part or the tibial part of the AFO is little forward. How you can do it? So what we want, this angle to the floor should be 6 to 7 degree forward. And how you can achieve it? A part of it can be done by placing the heel wedge below the heel of the AFO, and the other one can be raised by giving the shoes, because shoes also will give you 1 to 2 degree of elevation, right? So now the AFOs is might be in -2 degree of plantar flexion, little after 90 degree, but by putting the heel wedge and the shoes, you get it 6 to 7 degree forward. This is how it should be tuned, right? So what is the reason behind it? I explained it in my previous videos answering the questions about below knee serial cast, that when you don't have control at ankle and you don't have enough dorsiflexion or range of motion, there is no point of creating an articulated AFO, right? Because it's going to create a further pressure at the talonavicular joint, right? So you don't need to have an articulated AFO if you don't have a range. You don't need to stretch the calf and build up a tension or break the mid-tarsal joint even further. So you make static AFO, okay? And when you make static AFO and get the tibia forward, because that is how essentially when you walk, the stance side of the tibia is in a mid-stance position, which is little forward and not 90 degree. So when this is little forward, all the proximal structures and the joints and the bony segments will be well aligned, right? So this is how the AFO should be tuned. There are few more things also needs to be taken care of, like, okay, giving little bit of a varus at the heel, or supporting the medial arch well, supporting the horizontal arch well. Sometimes if it is too pronated and you have corrected, this comes little up, so then you need to raise the surface below the first metatarsal also. Whether Do I provide the push-off? So whether the front part of the AFO needs to be malleable or fixed. If there is too much of flexion at the knee, you might want to provide more extension. So this remains solid. So there are many things there. You know, it's an ocean of information and a course by itself, understanding AFOs. But this is a baseline and most important piece of information which I am giving you right now. So just take care of this. This will also take you to have a very tuned AFO which your child will accept and will not get hurt into, and you will not get rejection from the child if you make it this way. This is how we make it, and this is how it has been prescribed. Thank you.